Actually can't be here tonight. She is away. So I'm going to be introducing the speaker we have from OHSU, Dr. Elizabeth Silverman. She has been faculty at OHSU since 2018 now. And she does both clinical and research and is doing some really exciting work in imaging for multiple sclerosis, which relates to vascular neurology. And so she's going to be discussing some of the newer technological approaches, including OCT, in this lecture. So we are privileged to have her on board today. Yeah, I'll let Dr. Silverman take over.
Thanks so much, Marissa. Can everybody hear me okay? Okay, all right. And I'm going to share my screen. Please let me know if you're not able to see that. And if anybody has any questions during the presentation, please feel free to stop and interrupt me. I don't have chat in front of me, but I'm always happy to stop and answer questions. So as Dr. Kellogg said, my name is Elizabeth Silverman. I am an assistant professor in neuroimmunology and multiple sclerosis at OHSU and am really excited to be speaking to you all today. I will be discussing the kind of foundational work that led to my current research right now, which is looking at microvascular changes, specifically in multiple sclerosis. And for the sake of this presentation, I'll spend the first about 50 to 70% of the presentation talking about some of the changes that we see in MS as it relates to my research. And then we'll pivot to talking about some of the changes that we see in other neurologic diseases, specifically neurodegenerative diseases, but also a little bit in stroke. So with that, I have no relevant financial disclosures. I do receive research support through the VA, and these are my objectives today. The first will be to discuss the impact of vascular comorbidities on multiple sclerosis, and then to define the role of vascular dysfunction in neurodegeneration. We will then spend time appraising recent research in investigating both vascular and microvascular disease in neurologic diseases in general. So we now know that vascular disease is an established contributor to MS-related disability, but this work really emerged over the past 15 years or so. Ruth Ann Marie out of the University of Manitoba brought a lot of attention to the impact of vascular comorbidity on multiple sclerosis, and the research shown here is some of her pivotal work from 2010. At that time, she conducted a large cross-sectional survey of about 9,000 people with multiple sclerosis and looked at the relationship between vascular comorbidities and disability progression in people with MS. And she found that at the time of diagnosis of MS, over 50% of respondents had at least one vascular comorbidity. 37% had high cholesterol, 30% had hypertension, 7% had heart disease, and 6% had diabetes. And in addition to this, 20% of people had two or more comorbidities at the time of their diagnosis. So she then was interested in gathering disability data and information on disease duration. And that's shown in this figure over here on the right. Let me see if I can get a laser pointer. Shown over here. And she found that while the presence of a singular vascular comorbidity increased the reliance on a cane by 50%, so that is this dotted line, as compared to this solid line. She also found that the presence of two or more vascular comorbidities increases the risk of relying on a cane by 220%. So this suggests not only that the presence of vascular comorbidities increases walking disability, but it does so in a dose-dependent relationship. Studies subsequently, which has shed more light on the relationship between comorbidity and MS. On the left here are the results from a study that used health claims data across Canada. She analyzed data from 24,000 people with multiple sclerosis and then went back and identified the rates of comorbidities 5 years prior. You can see that the rates of comorbidities increased dramatically over time. And in a separate study, she looked at the longitudinal changes in people with MS versus age matched controls. This is data from 44,000 Canadians with MS and 220,000 age, sex, and geographically matched controls. She's looking at the incidence of diabetes, hypertension, hyperlipidemia, and ischemic heart disease from 1995 to 2005. So, what she found is that over time, the age standardized incidence of diabetes rose more in the MS population than in the matched population. And she also found that the temporal trends in age standardized incidence of hyperlipidemia. Oh, wonder if that stopped sharing. Let me see if I can.
You can still see it.
Oh, you can?
But it
I
says,
can't see the presentation.
now it's
Yeah,
gone.
it stopped showing. Yep, there it
It's
is.
back. It's back.
Back up?
Wonderful. Thank you. Yep, good work.
Okay. All right. Um, So she found that the temporal trends in the age standardized incidence of hyperlipidemia, hypertension, and ischemic heart disease were similar in both MS and healthy control populations, but amongst those who are younger, between ages 20 and 44, the incidence of ischemic heart disease was actually higher in the MS population versus healthy controls. So this data in combination builds the case that comorbidity is closely related to disability in MS. So, over time, this work has been extended by a number of researchers who have found that vascular comorbidities are associated with a threefold worsening in visual quality of life, that adverse lipid profiles, especially HDL and LDL levels, are associated with more clinical activity on MRI, so new T2 lesions, new gadolinium enhancing lesions, and more clinical progression. And in addition, vascular comorbidities are associated with longer delays between symptom onset and diagnosis, and patients have had more self reported disability at the time of diagnosis. The burden of vascular comorbidities may be even larger than we previously recognized as well. A recent study 1,000 people with MS and 73,000 controls found that people with MS have a 60% higher risk of myocardial infarction even after controlling for vascular comorbidities. And this really echoes the work of Ruth Ann Marie's findings, which I showed on the previous slide, and suggests that people with MS have unrecognized vascular dysfunction with serious long term consequences. So, while vascular comorbidities are one method for understanding vascular dysfunction, they don't tell us much about the mechanisms driving this clinical worsening. And to take a step back, I wanted to spend a few minutes talking about how we conceptualize MS today. It was a bit different than how I was originally taught even 5 or 7 years ago. At that time, we really thought that MS was a disease of discrete phenotypes, that there was relapsing disease, secondary progressive disease, and primary progressive disease, and that they almost acted independently. Today, as shown in this schematic here, we actually think that this is a disease that is driven by both inflammation and neurodegeneration, and that the relationship between these two is driving the disease phenotype. So this is a schematic showing the different phases of disease in a specific patient with relapsing remitting MS. That patient will have a preclinical phase where they've never had any relapses, but if you were to image them, let's say they were in some sort of an accident, they needed to get an MRI, you may find that they already have MRI changes, so T2 lesions or enhancing lesions here. And today we would probably say this is radiographically isolated syndrome. And even at this phase, patients have accelerated brain atrophy as compared to healthy controls. Now, these patients then will go on and have their first clinical relapse, so this first sort of blip in this green line of their clinical progression, and with that will be diagnosed with MS. And if you do not get them on the right disease-modifying therapy, they may go on to have several clinical relapses and associated T2 changes and gadolinium-enhancing changes over time. And with these two, they can accumulate disease burden. You can see that they continue to have brain atrophy at this phase. And then for the majority of patients, after about 10 to 15 years, they convert to a different disease phenotype of secondary progressive MS. And here you can see that the number of clinical relapses decreases, although does not go away completely. The number of MRI lesions decreases, but you continue to have this accumulation of disease burden, and you see this acceleration of brain atrophy. So we think that progression to SPMS is really driven by neurodegeneration. And interestingly, progression to secondary progressive MS occurs independent of the number of clinical relapses that you've had in the past, suggesting that there's a unique underlying mechanism between inflammation and neurodegeneration in MS. We do know that this brain atrophy that we're seeing up here correlates with overall patient disability and cognitive impairment. And importantly, even though we have over 20 MS approved medications at this point, while they are highly effective at controlling inflammatory disease, they have minimal effects on neurodegeneration and progressive disease. So I believe that vascular dysfunction is intimately tied to both inflammation and neurodegeneration in MS, and is therefore a prime target for improving patient disability. So the link between vascular dysfunction and inflammation and neurodegeneration in MS is perhaps most clear at a cellular level. We know that focal vascular disruption of the blood-brain barrier often precedes MS-related inflammation, and this disruption is present in both relapsing and progressive phenotypes. The blood-brain barrier is composed of endothelial cells, which are tightly regulated and cells between the bloodstream and the central nervous system, and damage to this blood-brain barrier is both an early and pervasive feature of MS pathology. And this focal damage is ultimately what is driving the hallmark inflammatory plaque of MS. This figure here shows some of the typical pathologies of MS. In panel A, we see a Luxol-Fast blue stain showing acute periventricular white matter demyelination in this tan area, with the blue staining the myelin here. And a high-powered view here is shown in panel B, where you see a CD8 positive staining cell in very close proximity to the vascular lumen, showing the close relationship between vascular dysfunction and the blood vessel wall. Changes to the blood-brain barrier are shown in C and D. These are immunofluorescence and confocal microscopy sections from normal appearing cortical gray matter in a patient with primary progressive MS. And the green fluorescence is showing tight junction protein Z1 or Z1 reactivity. In panel C, you can appreciate that there is a linear deposition of Z01 showing intact vasculature here, but in the same patient in panel D, there are these areas of disruption, indicating disruption of the blood-brain barrier. Ultimately, this disruption is what is facilitating inflammation, which transects axons, leading to neuronal death and driving whole brain atrophy. And while the pathologic studies can show vascular dysfunction in focal areas, MRI studies show that this vascular dysfunction is more global as well. This is a dynamic susceptibility contrast perfusion MR imaging study at 3 Tesla. And this imaging technique is an MRI-based technique that uses a very small bolus of contrast and then rapidly does sequential imaging to visualize the smallest caliber of blood vessels. Through advanced processing, data is extracted, which calculates cerebral blood flow, cerebral blood volume, and mean transit time of red blood cells. So in this study, we have 22 healthy controls, and then 11 participants with relapsing remitting disease and 11 patients with primary progressive disease. And here you see a heat map where green color indicates less blood flow, red color indicates more blood flow. And you can begin to appreciate just visually that the primary progressive patient, as well as the relapsing remitting patient, has less global blood flow as compared to the healthy controls. When you then look at this regionally, you can see that these differences are statistically significant. This is looking at cerebral blood flow, cerebral blood volume, and this is divided by region. So frontal, normal appearing white matter, occipital, normal appearing white matter, periventricular, normal appearing white matter, as well as the splenium. So both globally and focally, you're seeing disruption in these various measures of blood flow. So what are the consequences of this decreased blood flow? This is a theoretical model that was presented by Bruce Trapp's group in the Lancet Neurology nearly 15 years ago. And he juxtaposes the differences in a traditional model of ischemia, as we might see in stroke, to what we see in MS. And I thought it was an interesting way to conceptualize some of the challenges that we face in attempting to treat multiple sclerosis. In the center, we have a model of a healthy neuron. On the left, a model of ischemia, as we might see in stroke, and on the right, multiple sclerosis. So in the middle, undamaged neurons have this healthy balance between the amount of energy generated by mitochondrial metabolism and the requirements for action potential propagation and axonal transport. And at one end of the injury spectrum, such as stroke, you have an intact axon that all of a sudden has a severely energy limited environment due to a drop in your supply or your blood flow. This means that there is unmet demand, and this results in acute necrosis of white matter elements and acute injury. By contrast, in multiple sclerosis, you have a baseline disturbed architecture from chronic demyelination. And this means that you have inefficient conduction and greater translocation of ions per action potential, greater ionic leak at base as well. And this in turn leads to a higher metabolic load, increased energy demand, and at the same time, mitochondrial energy production might be compromised due to defects in the electron transport chain, ambient levels of nitric oxide, etc. So thus energy is reduced below normal, demand is increased overall, and even if supply remains the same, this imbalance is going to drive chronic necrosis, a state that he calls virtual hypoxia. You can imagine then within this model that anything that further disrupted supply would further contribute to this imbalance, driving brain atrophy overall. And this working model is supported by work that was done in our group at OHSU. This is research done by Dr. Vijay Yadav, who is the director of our MS Center. This is preliminary work from a 7 Tesla spectroscopy study of people with MS with and without vascular comorbidities. She found a decrease in ATP to total phosphate signaling, shown here in individuals with MS with vascular comorbidities compared to those without comorbidities, confirming that the presence of comorbidities leads to impaired metabolic activity in the brain. Subsequent analysis to look at longitudinal changes over time from this study. So this really sets up my current working model, which is that clinical and subclinical vascular dysfunction exacerbates MS-induced hypoperfusion, worsening virtual hypoxia, thus accelerating neurodegeneration. So vascular dysfunction is an important and under-recognized risk factor for clinical disability in people with MS and is therefore a prime target for neuroprotective therapies. In order to help answer this question, though, I needed a good way to look at blood vessels in the brain. And this is surprisingly challenging to do, but the platform that I use is based on OCT. So I'll spend a few minutes talking about OCT to lay the foundation for the technique that I use, which is called OCT angiography. So OCT, or optical coherence tomography, I imagine many of you are familiar with this technology. It's a non-invasive method of using light waves to take cross-sectional images of the retina. The retina is a unique model of neurodegeneration and neuroprotection because it contains no myelin. And the organization is useful because specific changes in different structural levels of the retina reflect axonal damage. That's specifically the RNFL, that's the layer that you see up here. Whereas changes to the ganglion cell layer or the inner plexiform layer shown here can show cell body loss. So myelin only becomes a part of the optic nerve behind the eye at the level of the lamina cribrosa. So retina can be really used to focus on the neuronal of multiple sclerosis pathological changes. And while MRI has really helped us measure tissue injury in MS, the technology is not as adept at looking specifically at axonal integrity. So this is OCT's niche. You can really directly measure axonal data scan that just takes seconds. So this is a typical view of what an OCT scan looks like. This is the section of the retina that we are visualizing, and in cross-section, you can see these individual retinal layers shown here, and you can appreciate that you can really visualization of the retina. As I mentioned before, the retinal nerve fiber layer here can measure axonal damage. The ganglion cell and inner plexiform layer here can really look at changes within the cell bodies themselves, and then there are deeper structures here. This is what a typical printout from an OCT looks like that you might get if you are seeing a report from a machine. All of the numbers here are oriented in this sort of radial pattern, and there are heat maps that indicate how this individual patient's retinal thickness levels compare to their age-matched controls. So normal values for retinal nerve fiber layer thickness are available for age-stratified populations, and the average decline is about 0.17% per year. So the OCT is a very stable measure to look at changes in retinal thickness over time. So there has been an enormous amount of work on OCT in multiple sclerosis, and probably more research than could fill this hour or probably 2 hours of talks. But to give a few brief highlights, we have found that retinal atrophy, specifically thinning of the retinal nerve fiber layer and the ganglion cell inner plexiform layer, are ubiquitous in MS and occur in MS with or without a history of optic neuritis. We have also found that accelerated retinal thinning in both the retinal nerve fiber layer and the GCIPL is associated with clinical disability. And cross-sectional assessment of the retina is also associated with disability. So if you take a single patient and you look at them at one time point, if they have really accelerated thinning, that can be a marker of having more brain atrophy over time. Research has shown that the RNFL is more subject to artifact than the deeper retinal layers, the GCIPL. It's more prone to edema in acute optic neuritis and can lose sensitivity with very severe retinal atrophy. Therefore, the GCIPL is the most common parameter that we look at in clinical trials. And this really has become a standard measure in clinical trials today. This is a review article that was published back in 2018, so almost 5 years ago. And even at that time, in just looking at phase 2 and phase 3 clinical trials using OCT, you can see that there were already over a dozen trials that were using this as an outcome measure. This is now considered a standard outcome measure looking at brain atrophy in trials of both anti-inflammatory medications and neuroprotective medications in MS. So on this foundation is OCT angiography. OCT angiography is providing the same structural information as OCT, so you are still getting visualization of the structure of the retina, but in addition, information about the vasculature of the retina as well. This is a printout of what we see in an OCTA scan, and you can actually toggle between the different layers of the vascular plexi. From an anatomy perspective, you can see that there are different vascular plexi. The terminology here is a little confusing, but the SVP stands for the superficial vascular plexus, which is composed of the superficial capillary plexus. And these areas specifically have the blood vessels that are feeding the RNFL and the GCIPL, those layers that I told you we are following as clinically significant measures of brain atrophy in multiple sclerosis. There's also the deep vascular complex down here feeding the deeper layers, and the outer retina down here actually is devoid of vasculature. In addition, there is another vascular complex located right around the optic nerve here, the radial capillary plexus. So these are the blood vessel areas that we're looking at within the kind of neurology extension of this technology. Some of the foundational studies using OCTA in MS were done at OHSU. This is a research study that was published back in 2018 by Dr. Rebecca Spain, one of our MS neurologists and one of my mentors, as well as David Huang. Dr. Huang is at the KCI Institute and works in the Cool Lab, and he was one of the original co-inventors of OCT technology, and has really brought that technology to OHSU and is also one of my mentors. In this study, they are using a slightly older technique, angiography, so they're looking at but it's still looking at blood vessel changes. They enrolled 45 MS participants and 32 healthy controls, and found that of people with MS, they have decreased vasculature if they have optic neuritis, or if they don't have optic neuritis. So statistically significant difference healthy control and without optic neuritis. In addition, they found substantial thinning of the retina, as would be expected here. And their conclusions from this is that the combination of perfusion and structural measurements enhance the detection of optic nerve damage in MS. Therefore, OCT angiography may be a useful additional marker in evaluating optic neuritis in MS. So from this early work, there has been a relative explosion research done in this area. This is a meta-analysis that was published just a few weeks ago, which is looking at all of the data to date of people using OCTA in MS. All of these studies are cross-sectional studies, but what we find overall is that the decrease in the macular SVC and peripapillary vessel densities in MS versus healthy controls is well established and consistent within. I just got a request to annotate the content. I'm going to decline that, but if somebody is interested in asking a question or needed to annotate, just send me a message in the chat and I can go ahead and approve that. So the macular superficial vascular complex and peripapillary vessel densities are significantly lower in MS versus healthy controls, irrespective of their history of optic neuritis. And further, the results show that the superficial vascular complex and peripapillary vessel densities are lower in MS eyes than in MS non-optic neuritis eyes, suggesting that both the macular and peripapillary microvascular alterations may be greater due to MS-associated optic neuritis. Now, how does this correlate with what we see clinically? This is work done by Olwen Murphy and colleagues out of Hopkins, and they were the first to correlate changes in the retinal microvasculature and measures of MS-related clinical disability. This is a cross-sectional study of 111 people with MS and 50 healthy controls. And they are showing the macular superficial vascular plexus and deep vascular plexus densities. They found that the superficial vascular plexus densities correlates with reduced visual function, longer disease duration, and higher levels of global. However, of note, they also found that retinal thinning also correlates with worsening clinical outcomes. So they then wanted to look at the relationship between retinal thinning and vasculature, and that is shown here. And you can see that there's very clearly a tight linear relationship between the thinning of the retina and the drop in vascular density. And that's true for both MS eyes as well as control eyes and MS eyes with and without optic neuritis. So that really leads to the question of what comes first, blood vessel loss or structural loss. And that really needs longitudinal data in order to be able to help answer the question. So that was where my first research question came from. In early demyelination, can changes in retinal microvasculature predict disease activity? So we set up a pretty simple study. We wanted 15 participants with multiple sclerosis or clinically isolated syndrome. So those are people who do not yet quite meet the classification for multiple sclerosis, but have had a demyelinating event. All individuals were diagnosed within 5 years or had relapses within the past 6 months. The idea being we wanted to capture patients who were still in a dynamic phase of their disease and having active changes in both their retinal thinning as well as their vasculature. And then we did frequent imaging at baseline, 3 months, and 6 months. We collected a number of visual outcomes as well as OCT and OCTA measures. These are functional clinical outcomes, and then this is a disability scale. And we're still analyzing this data, but I wanted to show longitudinal data from a single subject who had acute optic neuritis during the trial. So I arranged this showing time after acute optic neuritis to kind of give a clinical context with which to understand this data. These are just the images of the retina here. The reflectance is a way to pull out some artifact. RNFL thickness is looking at the structural measures here, with green being normal levels of retinal thickness and red showing areas of thinning. And then this is a heat map showing vascular density. The RNFL capillary density is the blood supply of the RNFL structural measures. So we're looking at vasculature and structure side by side here. And you can see that as this patient extended out from their time of optic neuritis, they developed actually pretty substantial retinal atrophy, where they now have all of this area in red here. And you can visually just appreciate the increased area of dark blue here, showing that there is increased vascular dropout corresponding with this area of thinning here. So looking at this data in a different way, we can see that the structural changes for this individual following their optic neuritis are quite clear. There's a substantial drop in the retinal nerve fiber layer and a little bit of an uptick here, but in general, a drop in the IPL layer. But the vascular changes are moving up and down. There seems to be some variability in the vascular measures here. So this very early work suggests that perhaps the structural and vascular measures may move independently in a subset of patients earlier in their disease. And we're currently working on gathering longitudinal data from healthy controls to understand how much variability we see in these vascular measures over time. A similar finding was reported in the only other longitudinal study published to date. This was a study done out of Dr. Lanzillo's lab out of Spain. She analyzed 50 patients with MS who underwent OCT and OCTA at baseline and after care, and she found that for a subset of patients, they actually had improvement of their vasculature over time. And those individuals that had improvement over their vasculature had less over that same time. So again, for a subset of patients, they seem to be able to have some recovery of their vasculature early in their disease, and that this is perhaps an indicator of somebody who has less disability accumulation and perhaps less disease severity. So we're still doing ongoing work to understand that research, but I also wanted to take a moment to my other research study, which I currently have going underway. In this study, we are looking at whether changes in retinal microvasculature can predict neurodegeneration in people with MS. So, this study is a bigger study. It's a 2-year longitudinal study in which we enrolled 22 people with MS with vascular comorbidities, so hypertension, hyperlipidemia, diabetes, 22 people with MS without vascular comorbidities, and then 22 healthy controls. And we're gathering a number of clinical outcomes. We are getting clinical assessments, including a outcome, a disability scale. We're doing our visual assessments as well. And then we are also and we're banking some serum and some plasma to do additional add-on studies. We're then doing MRI assessments looking at whole brain atrophy, as well as regional atrophy and arterial spin label imaging as a way to look at the vasculature within the brain. And the hope is to be able to use this data to be able to address the following aims. So aim 1 is to characterize the impact on retinal microvasculature in people with MS. And we intend to do cross-sectional analysis of retinal vascular density in healthy controls in people with MS to understand the relationship between the two. Aim 2 is then to look longitudinally at the retinal microvasculature in people with MS and measures of brain atrophy and see whether changes in the vasculature correlate with changes in whole brain atrophy as measured through our MRI at baseline in 2 years. And in aim 3, we're looking at the relationship between those longitudinal changes in the retinal microvasculature and limitations in activity or measures of clinical disability. So that is the overall aim of that study. We're fully recruited, and we should complete our data analysis in the next about 20 months or so. And then hopefully we'll be able to come back with some more information to share. I'm also working on a collaboration with the Advanced Imaging Center, looking at a link between OCTA and that MRI technique I discussed earlier, DSC MRI, or the dynamic susceptibility contrast MRI technique, which is looking at changes of MRI measures at the capillary level and how those correlate with our OCTA findings. So that's another exciting collaboration that we're hoping will provide more information about how good the retina is as a model of neurodegeneration in MS. So with that, I'll transition to talking about OCTA in other neurologic diseases. And I'll start by talking about Alzheimer's disease. Within the world of Alzheimer's disease, there is great interest in establishing structural biomarkers to use to measure disease progression, as well as to follow for possible therapeutic agents. And in Alzheimer's disease, there is evidence that there is choroidal thinning, which is really early evidence that vasculature in the retina may be impaired. And interestingly, beta amyloid plaques are found in the retina, and it's been postulated that they may actually cause compressive forces on the retinal cells and the blood vessels, thus reducing blood flow to the retina, which is one of the most energy-consuming tissues. In addition, the vascular endothelial growth factors, which are produced in response to retinal hypoxia, can't bind to their receptors due to amyloid deposition, so retinal blood flow cannot be supplied. So there are a number of sort of mechanisms that may be that may be involved in decreasing vasculature within the retina in Alzheimer's disease. And in fact, a number of studies have shown that this is the case. This is a meta-analysis that was just published in the past year, which is showing that there is significant differences in the retinal microvasculature in Alzheimer's versus controls in both the whole superficial vascular plexus, so the same area of the retina that's affected in MS, as well as the parafoveal vascular plexus. Now, one interesting study that I wanted to highlight, this is work done by Fanny Elahi out of UCSF, and she was interested in knowing whether or not ApoE carrier status influences retinal microvasculature. So she conducted a really interesting study where she enrolled 75 cognitively normal individuals, and of those individuals, 32% were ApoE carriers. And she then looked at the retinal capillary density divided by ApoE status and you can see here that ApoE carriers are shown in red, whereas non-carriers are shown in blue. And she found that there is a statistically significant difference in retinal capillary density between these two groups, even after controlling for age, sex, systolic blood pressure, and BMI. And 14% of the variance in retinal capillary density can be attributed to ApoE genotype, independent of vascular risk factors. She did a sub-study where she compared the retinal capillary densities in a group of individuals with positive versus negative amyloid PET scans and found no differences in capillary densities between these two groups. So it indicates that perhaps early amyloid deposition in individuals with ApoE carrier status may be influencing the microvasculature even before patients have clinically evident cognitive changes. So I think there will be more research focused on this, but this raises some possibility that OCTA may be an interesting biomarker to screen individuals early on in their disease process, perhaps even preclinical dementia patients, in order to identify some of these very, very early differences. There are also interesting OCTA studies being done within the world of Parkinson's disease. And this is an area that I really did not know much about until I started putting together this presentation. So it was fun for me to read about this. There are many different components of vascular abnormalities in Parkinson's, and early pathologic studies done nearly 90 years ago described that there were changes in the capillary network in the substantia nigra. So they found that there was pathologic angiogenesis seen in patients with Parkinson's disease, and that's typically seen in response to inflammation or hypoxia. And in animal models of Parkinson's disease, you can also see increased vascular density with more branch points. There are different mechanisms that are suspected to this, but we do know that there can be activation of Parkinson's disease, perhaps as a response to inflammation or hypoxia, and pericytes line the microvasculature and are important in angiogenesis. And you may think more blood vessels, well, maybe that's a good thing, but these vessels can be immature, and immature blood vessels can lead to blood barrier breakdown as well. And you can also see evidence of endothelial degeneration. So you have this combination of angiogenesis and vascular regression in Parkinson's disease, which are occurring in symbiosis, making the relationship between vasculature and Parkinson's disease pretty complex and hard to suss out. see some deposition of alpha-synuclein and visual symptoms that can actually occur early in these patients with impaired color vision and issues with high contrast acuity. So studies have shown that there can be decreased perfusion density in early stage Parkinson's disease, and the authors hypothesize that perhaps alpha-synuclein deposition in the artery walls may influence the vasculature. And there's also retinal thinning in these patients as well. One interesting study looks at the capillary complexity in Parkinson's disease. So this is a study of 25 people with Parkinson's disease, 25 age and gender matched controls. And they do this interesting technique where they pull out the retinal capillary skeleton density and then the capillary complexity. So it's sort of a fractal analysis of how complicated this network is between these two populations. And they found that in patients with Parkinson's disease, they had both a lower capillary skeleton as well as lower capillary complexity overall. So it's an interesting technique that could be particularly useful in Parkinson's disease when thinking about this complicated relationship between angiogenesis and pruning of the vasculature as part of the disease process. Finally, at OHSU and the Junger Center, Anusha Mishra is doing really interesting preclinical work looking at the impact of stroke on cerebrovascular dysregulation. She has done a lot of work looking at neurovascular coupling at the capillary level, and it's found that in animal models of stroke, you can see changes in the vasculature, both in the infarct bed, but also in the peri-infarct region, so the area right next to the stroke, and then actually the contralateral side of the brain as well, showing that changes in neurovascular coupling are widespread throughout the brain. And she's now extending that work into Alzheimer's disease, as cerebrovascular dysregulation seems to be an early biomarker of Alzheimer's disease. So there are a lot of areas for future investigation. Some areas that I'm particularly interested in are whether vascular density can predict MS disease phenotype and disease activity. I'm really interested in knowing whether or not changes in vascular density affect the neurovascular unit. So really bringing that question one step further to know how do the changes in blood flow affect how themselves, and then also really establishing how we extend our OCTA findings into the brain with some of these advanced MRI techniques. So there's a lot more work to be done, but it's a very exciting area, and I appreciate having the opportunity to share it all with you today. I'd like to acknowledge my mentor team, Rebecca Spain, Dennis Bordet, and David Huang, my collaborators, my research coordinator, Emma Young, and the rest of the MS Center and the Cool Lab. And with that, I will stop presenting, and I'm happy to take any questions anybody.
Elizabeth, thank you so much. Can you hear me?
I can, yeah.
Oh, thank you. That was fantastic and very well delivered. Very exciting work. Thank you so much.
Thank you.
Thailand, yes, please. BDMS, I see a question.
Thank you very much, Dr. Silberman, for your very intensive and wonderful lecture. I see you involved with the Parkinson disease, which is my subspecialty. I don't know. Now it seems like there are many hypotheses that causing Parkinson disease. But I don't know. This is one hypothesis, right? I mean, for the vascular abnormality in Parkinson disease, which I don't know how it's gonna be in the future, though. Mm-hmm. So you look at the retina, right, to see whether what changed in the retina, and you look at the progression of some like Alzheimer, Parkinson disease, some neurodegenerative disease compared to the multiple sclerosis, right? Yeah.
Mm-hmm. Yeah. So I think that one area that that I'm starting to think about more is MS is certainly an inflammatory disease, but it's also a neurodegenerative disease. And as we think of it as a neurodegenerative disease, we can see that it faces many of the therapeutic challenges that Alzheimer's disease, that Parkinson's disease, that many of our other neurodegenerative diseases face, which is how do you save brain tissue in addition to treating symptoms, right? That's a very big question. There are a lot of different areas of research that are focused on answering that question. But one of the things that we have to establish is a reliable way to measure brain shrinkage over time in order to assess those treatment options. And I think that OCTA may have potential in that space because putting people through MRI scans over and over again is both time consuming, is very, very expensive, and can be prone to error, which is one of the advantages of OCT. I didn't speak too much about it here, but from a cost perspective, OCT has many advantages. It's much less expensive to do, does not require as much technical skill to run the machine over and over again. And I think that's another potential advantage when thinking about how we might monitor our patients moving forward. That being said, the disease process of Parkinson is unique in its own way, right? So the way that we might save brain tissue in Parkinson may end up being very, very different from our approach to saving brain tissue and preventing neurodegeneration in MS. So I think that there's a lot of nuance in really connecting those disease states.
Thank you for your answer. So I think there's some research doing like beta amyloid deposit in the retina also.
Mm-hmm.
I don't know for like Alzheimer disease, is that like still have a good outcome for that research? I'm not sure though, but for Parkinson's disease also we cannot do the alpha synuclein scan yet though. So I know maybe some problem with the retina or something that we can tell whether I don't know, it can use for early diagnosis for of this patient, like you say, for ApoE carrier, right?
Right.
Even they don't have Alzheimer disease.
Right.
Even the PET scan still negative, but
right.
You see some change in the OCTA, right? Yeah.
Right.
Very
right.
wonderful job.
Yeah. And I think that that's a really exciting aspect as well. And I think builds the case of the retina is a really powerful model of looking at the brain, even though it's not a complete model. So it would be helpful to be able to have an earlier identifier of patients who have these, who may be at risk for developing long-term sequelae. I think one of the challenges certainly in Alzheimer and likely in Parkinson as well, although I'm sure that you would know better than me, is by the time patients might come to medical attention, it may be relatively late in the disease process. And then even if we did have good therapeutic options, have we captured patients at the right time? The ideal is if we can identify patients early enough that they don't have substantial brain shrinkage yet, then maybe we can capture that window where patients may be more amenable to treatment. So that's sort of my optimistic view of things, but I hope we're able to see that as a future in treating our patients.
Thank you very much. Is there any other question from Thailand? Dr. Chantila, Dr. Nandasak, or other side?
Hello everyone, and great lectures. I saw some question from the chat that they're asking that do we use an OCT in our center? So we do use it in MS patients, especially most MS, NMO, and MAC antibodies patients. And I have some questions like you say that the atrophy of the OCT can predict it for the MS progression, right? But currently we still not using it as a choice in the decision making for the change of the treatment. And what do you think, like if we found atrophy in the OCT, but there is no new lesion in the brain, do you think that this is change anything on the decision making and treatment options?
That's such a good question, and it's funny to hear the question now. When I was interviewing for fellowship to come to OHSU, so I was still in my residency. Our chairman at the time actually asked me that same question. He said, "Should I buy an OCT for our center and scan everybody?" And I froze because I didn't know what to say. You know, I think the answer is right now, it pains me to say it. I don't think our information is at a point where we can act on it clinically. And I think the reason for that is that of our MS medications right now, we don't have a good medication for neuroprotection. I think if there was a really good medication on the market where we said this is reversing brain atrophy or is slowing shrinkage, then perhaps we could use that. But all of our medications right now, with perhaps the exception of the S1P medications, fingolimod or things like that, we're not seeing much change in the brain shrinkage. And I think it's likely because the process of neurodegeneration is different from the inflammatory process. So this may be an area where the technology is there when we have the neuroprotective medications ready to go. My hope is that the MS scientific community has been so focused on anti-inflammatory medications for so long, and we have a lot now. The neuroprotection therapies are the real area where we I think need to focus in order to help address that long-term disability. Once we have those medications, then I think OCT may become really powerful to use. As a sort of separate area is that there has been some research looking at both changes in OCT as well as OCTA patterns in distinguishing MS from neuromyelitis optica spectrum disease or MOG-associated disease. And there you can see some differences in patterns of retinal atrophy and in vascular dropout. And because those medications have some different therapeutic options, that could be a sort of actionable piece of information that you could incorporate clinically.
Okay, thank you very much.
No, thank you.
Is there any other question from other center? Please. ท่านนันทศักดิ์มีคอมเมนต์อะไรไหมครับ
Thank you very much, Dr. Zimmerman. One thing is that when you look at the OCTA, what about the difference between, or you have any clinical correlation? For one thing is that about the OCTA and retina degeneration and brain atrophy. How can we use OCTA as a prediction, and which one is the come first from the retina degeneration and reduce the OCTA number or the vascular lesion in the retina?
So there's good established research showing that thinning of the ganglion cell interplexiform layer on our OCT scans, as well as the retinal nerve fiber layer, correlates with decreased general visual acuity, so like a logMAR or a Snellen visual acuity, but also low contrast letter acuity, which research has shown is more sensitive for identifying visual difficulty in people with MS. It also correlates with our overall disability scale in MS, as well as overall disease duration. So there's good correlation between those with both OCT measures in the retinal nerve fiber layer and the ganglion cell interplexiform layer. There have not been enough longitudinal studies with OCTA, I think, to be able to use this to predict the measures of clinical disability. My hope is that my research study will provide some information, although the study is relatively small. So hopefully by the time we have that data, we can perhaps do a meta-analysis to look at the work of other groups to see whether or not there might be enough power to predict measures of clinical disability with the vascular measures within the retina.
Thank you.
For some background for everyone, why I invited Dr. Silberman to speak. I know BDMS is a cutting edge healthcare group, and I thought this was a little different than the lectures that we normally give, but it kind of brings together the vascular focus that we've had as a partnership, and also introduces some of the neuroinflammation, and also dives into a newer technology. So I thought it would be a nice and different lecture to have. But we welcome your feedback on for future lectures for the rest of the year, because later lectures from OHSU are going to happen later. So if there are any other, we have a list of topics that were requested, but we welcome your feedback for future lectures. So.
A very big thank you to Dr. Silverman too. Fantastic presentation. So enjoyable to learn so much about so many conditions and the impact of such a cutting edge technology. So thank you all. Good to see you all. Kapkon Kap. Wonderful to
Thank you.
be a part of
Thank
this.
you. Bye-bye. Take care. Thank you very much. Bye-bye.